I'm Anna Kent. I'm a neuroconditions clinical specialist, and this is my colleague Karen Palmer, who's also a neuroconditions clinical specialist. And we're going to give you an overview of motor neuron disease, and it's literally going to be dipping your toe in the water because we could probably rattle on for days. So it's a starting point, and hopefully we'll give you an overview and also provide you with some ideas of where you can get additional information to keep your learning journey going. That's where I'm hopefully aiming for. So when we were talking to our patients about this afternoon, or today in fact, they were all really excited that people wanted to know more about these rarer conditions. And I was talking to one of our MND patients, about what would they like to say to you as an audience. So they very kindly typed me something and emailed it using their eye gaze system. And Karen is going to read it to you.
I've had a very mixed experience with professionals in my MND journey. Some are brilliant and show great respect and empathetic skills and the ability to assess their patient's intelligence and tailor their conversation accordingly. However, I've experienced lots of healthcare professionals who have spoken to me as if I have special needs, and one in particular thought I had learning difficulties because I can no longer speak. Additionally, I have experienced lots of times where the health professionals do not give me time to answer their questions on my eye gaze or speak to my wife instead of me. I'm an intelligent adult who needs an advocate for myself.
So that's a perspective of someone with MND, and it's that time, giving people time, and I think that is so, so important. So I thank them because I think that was really important. It's stuck again. Alex, it's stuck again. It's not me. I promise. Come on. People have got places to go. So, faces of motor neuron disease. Top left, Coronation Street. We had a storyline. MND, yeah. Then we've got Dodie Weir, who is a Scottish rugby player. Diane Pretty, a good few years ago, lady with MND that went to the European Court wanting the right to die. One of the Ronnies, and I always get this, is it Corbett? Ronnie Corbett. He had motor neuron disease and actually deteriorated really quickly. There we go. David Niven, and he was an actor, and he had MND. He went on the Parkinson show years ago, chat show, and he was accused of being drunk because he had a slurred speech, slurred voice. Okay. Lou Gehrig, bottom left. So he was a New York Yankees baseball player, and in the States, they refer to motor neuron disease as Lou Gehrig disease. I think it was number 42, New York Yankees. We've got Stephen Hawking, and in the middle, Rob Burrows, thank you. Got thought apnea. Rob Burrows, who's obviously been really, really high profile in the world of MND. So just a sort of starting point, sort of the various faces. Oh, wrong way. Does work. It's just me. So, what is MND? Well, it's relatively rare. It's fatal and will progress rapidly, and it affects the brain and the spinal cord. And the motor nerves, so the nerves that control movement, sending information from the brain and down the spinal cord to the muscles, no longer work. Doesn't normally affect the sight, sound, and touch. It can leave people locked in a body, unable to move, talk, and eventually breathe, but they can still feel. So they know if they're uncomfortable, if they've got an itch they can't scratch, they know that they can't breathe. They can hear, they can communicate. And I think back to when I started doing this job, my way of communicating with someone with MND was an alphabet chart on the back of a table mat, going through every single letter. Now we've got eye gaze systems, we've got all sorts. It affects people from all communities. And some people may experience changes in thinking and behaviour, and we may get a rare form of dementia also in some cases. So what happens? So the motor nerves carry messages from the brain down the spinal cord, and they're a bit like an electrical cable, to make the muscles work. And if those nerves aren't working, then the muscles don't work, and the motor nerves die off for some reason. The sensory ones stay intact, so sensation remains intact. So if you look at the sort of classification of neurological diseases, there are over 100 conditions that affect motor nerves, but 3 or maybe possibly 4, we use the umbrella term of motor neurone disease. And the type of MND will depend whether it's upper motor neuron or lower motor neuron involvement. So we've got different types of MND. Got the most common form, the ALS, amyotrophic lateral sclerosis. So if you're looking on American websites, look up ALS. That's the most common form. And that affects both upper and lower motor neurons, about 80% of cases. Average survival rate around about 30 months, okay, from diagnosis. You've got progressive muscular atrophy, and that's predominantly the lower motor neurons, 5 to 10%, 15% of cases, and you've got survival less than 4 years. And primary lateral sclerosis, and that's actually the sort of upper motor neuron involvement. Survival rate normally greater than 10 years. There's something also you might read about progressive bulbar palsy, but that's probably a subtype of ALS, and that's when you've got the speech and swallowing involvement initially. So it affects men and women in a 2-to-1 ratio, and it was first described in 1874, so it's been around for a while. It can affect any adult at any age, but normally between the 50s to 70 age group. The youngest person I had diagnosed is 22, so I'm slightly younger than the one that Dr. Butterworth saw. That individual is still alive and in his 40s, so diagnosed at 22. You tend to have a better prognosis if you're younger when you're diagnosed. If you think about Stephen Hawking, anyone seen his film? He was diagnosed, yeah, so he was really young. So one of the reasons probably why he had a better life expectancy. The incidence is 2 per 100,000, so 2 per 100,000 diagnosed. And that's actually the same as multiple sclerosis per annum, okay? So the same numbers diagnosed in MND per annum as in MS. However, your prevalence is 7 per 100,000, which is very different from MS. So you've probably got, it's a rare condition, 7 per 100,000. But if you think back to what we were talking about, life expectancy, that's the reason why. People don't live. They get the diagnosis, they tend not to live. Most GPs are unfamiliar with the condition. Your average GP will see 1 or 2 MNDs in their whole of their GPing, so people coming into GP surgery, they're not necessarily looking for that. Again, there's a red flag guide. So, you know, again, if your therapist dealing with people with a sort of neuromuscular condition, have a look at that, because there may be things in there you think, oh, that's useful to know. There may be some linkage with being super fit. There is the thought that people that exercise excessively, I'll be all right with that one, hopefully, have more of an issue with developing MND. Once the motor nerves die off, we can't undo that. We can't rewire people, unfortunately. The majority of cases, 90 to 95%, are sporadic. We don't know why. There's no linkage. It just happens. And we wonder whether there's we're still nowhere near getting an idea of the reason why. We know that it's probably a complex interplay between genes and environmental factors. And also we've got an aging population, so perhaps people are living longer. You know, if you think back to the 1900s, when people sort of average age of death was 47, so maybe people were sort of dying before we got the diagnosis. I also think people are being better diagnosed. I've seen huge sort of improvements in that. Probably also reassuring for people to know a relative of someone with sporadic MND is no more likely to develop MND than anybody else in the population. However, 5 to 10% of cases are familial. There is a genetic form of motor neuron disease, so in 5 or 10% of cases. So a few years ago, I had a gentleman that was diagnosed. His brother had died of MND and his mum had died of MND. So his 89-year-old father was left, having lost his wife and 2 sons, which was really sad. There was another lady, again, years ago, who went to her GP worried because she had symptoms of what she thought was motor neuron disease, and was reassured by the GP that she didn't have MND because it wasn't familial, even though her mum had died of MND, and it turned out she did have MND. But in general, we would say it's not familial, but there are cases. Just sort of worth saying. And I would say also that the MND Care Centre based in Oxford is really good at supporting people when they've got those concerns, and they've been good at seeing relatives as well with a referral in. After diagnosis, shockingly, a third of people may well die within a year, and more than half within 2 years of diagnosis. So that's a really rapid progression. The lifetime risk of developing MND is 1 in 300, and 6 people are diagnosed a day with MND in the UK, with approximately 5,000 adults. And it kills about 6 people per day in the UK, so just under 2,200 a year. And I think that's the thing with the cohort and our caseload of MND patients. Often the numbers stay the same, but the names change. And I think that's, I was just reviewing our caseload recently, and then probably in the last 10, 11 months, we've had 8 deaths, but we've probably had 10, 12 new referrals. So it's this ongoing. So that the numbers stay relatively stable, but the names change. And it has no cure. I think that was a question you were asking this morning. There is a medication, Riluzole, and I think there was a display on Teglatec, which is a liquid form of Riluzole, that will increase life expectancy on average by 3 months. So we're not really anywhere further on. I would say, though, the interventions that we now have in place, such as the non-invasive ventilation, the cough assist, PEG feeding, early PEG placement, that's increasing sort of life expectancy. But we're nowhere near getting anywhere other than that. When you look at sort of at someone that's perhaps newly diagnosed, when you're sort of trying to work out what their prognosis is likely to be like, I think one thing is the rate of change in the first year. So thinking back over the previous year, how things have changed. If that's been relatively slow, then that's perhaps going to have a much better prognosis than someone that is rapidly deteriorating. If we've got pure upper motor neuron or lower motor neuron syndromes, or just syndromes maybe starting off affecting a limb, an arm or a leg. A worse prognosis is if it's an early diagnosis, so it's obvious, things change really quickly for someone. The elderly don't do as well. Bulbar onset, so the speech and swallowing problems at onset of diagnosis, we know that they're not going to do as well. And early respiratory involvement. So they're the ones that when you perhaps go and see when they're newly diagnosed, you think, oh, this isn't going to go well. These people are going to rapidly progress. I think also because of all the issues around the pandemic, we've come across people more recently that have been a lot further down the disease trajectory, disease pathway, because they haven't been picked up early on. I know there were people that were being diagnosed, being admitted to hospital because they had swallowing problems and they were unable to eat and drink. And then it turned out they had MND. I had 2 gentlemen literally within a couple of months of each other, and they rapidly deteriorated. So your symptoms. Again, I urge you, within your pack there should be, courtesy of Karen, because she taught me all about getting QR codes, there should be, I got a little bit overexcited about it, but there should be within your pack a handout, and there'll be various, I think, relevant documents on there, which you can just sort of hopefully scan and get to the relevant information, because I think there's so much out there on the NMDA website. There's, again, the red flag guide I mentioned, but the symptoms, you may have that ongoing muscle weakness, the twitching, the fasciculations you see, and not just in the limbs, but maybe in the tongue. We all get them. You'll be sitting there tonight watching the telly and thinking, oh, God, there we go. So that's but an ongoing fasciculation. Muscle tightness and cramping, breathing difficulties, swallowing problems, saliva and mucus problems, speech problems, fatigue, emotional lability. So you find people with upper motor neuron involvement have quite significant emotional lability, which can be quite challenging for them because they may be laughing or crying sort of inappropriate and more easily. and also cognitive changes. And again, years ago, we used to say, oh, no, you've never had any cognitive problems with MND, but we recognise that up to 50% of people now do have cognitive issues. Generally, what's not affected is the taste, sight, smell, touch, and hearing. Continence is not generally affected. However, if you've got mobility problems and communication problems, that can affect your continence because you can't get to the loo. You can't tell someone you need a hand. You may need more support. We've got someone on our caseload who is really regimented about what they will drink, how much they will drink at a certain time, and it has to be within that because they are still continent. And they know if they have their fluid intake within this period of time, that their care visit will then coincide so they can go to the toilet. So still very aware, but very, very disabled and an amazing carers. Generally, sexual function and expression's unaffected, but again, if you've got problems with your physical functioning, that can have an impact. Eye muscles are generally unaffected, heart muscles and digestive processes as such. We've recognised now there's also an increased component of frontotemporal dementia in MND, and that's something that's being looked at more significantly. They've identified some genetic forms. So you may, if someone does have the frontotemporal dementia component, you may see a significant personality change. They're not the same person. They may become more disinhibited and perhaps exhibit sort of undesirable behaviours. They may become more impulsive. They may get stuck and perseverate and continue to conduct a specific activity. They may have difficulty with expressing themselves verbally and initiating things, and may also be withdrawn and failure to initiate activities and apathetic. And I think going back to what Dr. Butterworth was saying today about the importance of history taking, really, really important, finding out that family background. Had someone fairly recently that was in hospital and had been admitted with falls and weight loss and some cognitive problems, was quite withdrawn and been under the mental health services. Was on a medical ward, was under review, and the neurologist went down and examined him and thought he probably had motor neuron disease, so he was sent off for nerve conduction studies. I went to see the gentleman to introduce myself and found out that there was a family history of mum and dad had dementia. I wasn't quite sure. One ended up in a nursing home, one died before they could go into a nursing home. And then the gentleman's helpful visitor said, oh, your sister died of MS, didn't she? And the gentleman said, yes. So we reported this back to the neurologist, and it was felt that possibly this gentleman had a motor neuron disease with a frontotemporal dementia, and there was a specific gene, which is a C9 or 72 gene, rolls off the tongue, which the gentleman was actually tested for. We found out actually the sister didn't have MS, it was motor neuron disease. And obviously one of those parents probably had the gene. We don't know, it was way back, but that then left this gentleman with motor neuron disease, possibly with the genetic form. The blood test came back very recently, and in fact, he'd sadly died, but he did have the gene. So his daughter is at 50% risk, and she also has 2 children. So we're now in the process of sorting out genetic testing for her to see if she carries the gene. So it's just being aware of that. It's your turn. You're at this.
So just as an overview then, just as a reminder, so MND is complex and it affects all the systems. So you've got your movement and your posture, your speech and your swallow, your breathing and cognition. And everybody's experience is different. No 2 people are the same. Okay. So because everybody's journey is different, it's not possible for us to say and predict exactly how their pathway is going to pan out. There's no cure. So it's based on managing and treating their symptoms and just maximum their independence and giving them quality of life. Odd one.
So you've probably heard something fairly recently in the news about there's a cure for MND. Anyone heard about that? Mm-hmm. Right, okay. Something did come out. So the SOD1 is a genetic form. It's probably quite a good name for it, isn't it? Gene. They found there is one drug, torfersin, which potentially can stop the SOD1 in its tracks and potentially reverse it. So that's a slight glimmer of hope. As a result of that, the fact that there's recognised that if someone has this particular genetic form of MND, there is potentially something that can help. That's really encouraged people to go for the genetic or genome sequencing to see if they have that specific genes, which will hopefully give us more information in the future.
And is that supplied on the NHS?
It's all being, yes.
So that family that you're talking about, if they found that they had that.
So if they'd had the SOD1, yes, but they had a C9 or 72, which wouldn't at the moment. I mean, I think we just have to keep hope. I don't know, hands at the back and from the NNDA, I think we just have to keep hope. And I think a lot of the researchers are also clinicians as well, so it gets personal because they're seeing real people in clinic, so they're not just locked away. And I think collaboratively, internationally, they work really well together, which is huge.
And we've already spoken about the Riluzole drug, but a lot of people who are offered it do take it, and I think that's a lot of it is to do with the psychological benefits of that. But the symptoms can't be reversed. It only slows down the progress, and as we've said, it's only giving an extra 3 to 6 months of life. So we're relying upon our interventions, our care, use of technology to improve their quality of life. So when people are diagnosed with MND, they normally go straight to Google, look on the internet, and then they're going to learn that they're going to choke to death, and it's going to be a horrible death. We try and make that different. Their other fears are loss of communication. They're dependent on others as well, and that loss of dignity, loss of control, and cognitive changes. And until recently, MND was considered one of the neurological conditions where the mind wasn't affected, but now we know different. And with 50% the statistics of people that now go on to have cognitive changes, and then a small percentage go on to develop the full frontotemporal dementia. So speech and swallow, you've heard it's starting to sow seeds now, isn't it, that we need to act quickly, swallowing problems, so we're going to need to think about PEG, and while their respiratory function is good, we spoke about the difference between the PEG and the RIG to be able to benefit with their nutrition. There's a really useful web link, MyTube. That included in there?
Absolutely.
That's included. Really worth a look, and we signpost patients to that website so that they can have an informed choice and actually see the visuals of what's involved with the PEG placement. So it's really, really worth a look at that. Obviously, secretion management, that causes real distress for patients. The technical term, sialorrhea. I think I pronounced that right.
Yeah, I can't spell it.
And again, it's based on trying to treat those symptoms. And we use hyoscine, glycopyrronium that you've probably heard of. They also use atropine, which is normally used as eye drops, but it can be used off license for secretion management, and in the most serious cases, Botox. We've spoken about the different consistencies of saliva. I don't think I probably need to say that again. With regards to communication, 80 to 95% of people with MND will experience speech difficulties throughout their journey. We use to aid the communication, we use the augmentative alternative communication. So just to break that down, augmentative is supplement speech and alternative to replace speech. So there's lots of communication aids, obviously referrals to speech and language therapies, and the use of voice banking, which you've heard already. Some of the communication aids we use, so back in the day when, before my time, it was just a very simple alphabet, laminated piece of paper with the alphabet on, and technology has obviously improved, and the price of equipment used to be several thousands of pounds for writers for them to be able to communicate, and now we're using iPads and free software on phones as well. The eye gaze system can't be used for everybody, but if somebody's unable to use their voice, unable to use their legs, unable to use their arms, then it's a really, really useful piece of equipment to give them a virtual voice.
I think we've recognised since the introduction of the eye gaze systems, people are able to communicate so much more. So your interaction with them, whereas historically it used to be, you know, one blink for yes and two for no, or a thumbs up or thumbs down. Now people's ability to actually give you huge amounts of information, because their ability to use the gadgetry is phenomenal. And it is high tech, and I think because we see it more frequently, people think it's more readily available, and it's not as high tech as it is, but it comes through a specific, through the EAT service, which is a communication hub, which has to be referred into. So we don't have a closet full of voice, eye gaze systems. It's high tech. Just because you see them more, they're still very high tech.
Yeah. And it just means so much, doesn't it? We've got one patient specifically on the caseload, and yeah, it's brilliant. And she even demonstrated that it swears.
There was a time lag.
And she used to have it on speed dial, wasn't it?
Yeah. No, I asked her, I said, are you able to kind of use your language as well? Will it allow you to swear? But we'd gone on to a different conversation, and all of a sudden this word came out, so you can imagine. And voice banking we've already spoken about. Again, not suitable for everybody, and we've got to do that in a timely manner. So if they've already got vulvar onset and their speech is affected, then we need to act quickly or think of alternatives for them.
Milton Keynes was actually one of the pilot sites for voice banking a few years ago, so we really tried to be at the forefront of pushing things through and working with the organisation to the benefit of people.
Some people do prefer whiteboards,
yeah,
don't they? Just going back to a simple whiteboard and just writing, but obviously it's timely, so you just need to be patient. If that works for them, then that's what we do. And breathing. So it's not generally an issue with their lungs. It's more to do with the muscles from the diaphragm becoming weaker, and so we're looking into tracheostomy, which is very uncommon for MND. I haven't met anybody.
I think I've had one, and I think often if you're looking at conversations around trachea, it's about thinking about then the longer term management and how that's going to be safely managed in the community. So it's not something that you see a huge amount in this area. In other areas in the UK, you see higher numbers of people with tracheas.
Are they very difficult to manage in the community?
I think it's the problem of, like, it's lots of having people there to change and how, you know, if
the
you've got an appropriate
escalation
package of care,
Right.
how are you going to manage that, and getting, so even if you've got the funding, yeah, we can fund that package of care, having the skilled carers to provide that care. And I think it's that making sure, you know, if you're looking at having those conversations, it's and what. So it's not refusing people, it's about the logistics.
Just in cases.
Yeah.
safety.
Yeah.
Safety. Yeah. NIV, non-invasive ventilation, that's used, I would say, quite a lot for our MND patients.
So Milton Keynes is the highest referrer to the sleep and ventilation unit for respiratory support, for which we apologise, but they said it means that you're being proactive. So we're hopefully preventing some of the secondary respiratory failure leading to hospital admission.
And potentially ITU.
Yeah.
We also use the cough assist machine, so that if you've seen these, they're not freely available. You can't get them from a cupboard. So it's just to reiterate that is for specialist use after they've been assessed properly. Suction, we have the suction machines that can support with the suction. There's no community respiratory team in Milton Keynes, just to be aware of that we have great links with Oxford for the respiratory team, and sleep and ventilation services there, they're wonderful. We have to care with oxygen for patients with motor neurone disease. I think the slide is in a couple of slides along. Yeah. So this is a really important card useful for paramedics or in that emergency, because they
have a copy in your pack along with the link.
They shouldn't have the additional oxygen. So the paramedics need to be aware. We do try and upload that to each GP record so that the GPs are aware, and it's on there if anybody needs to access from emergency services. They've got those details, and every patient is provided with one as well. It's worth knowing about. Let's do that one, Anna.
All right. So if we're looking at sort of indicators of respiratory muscle involvement in MND, you can check someone's forced vital capacity, their puff. If it's less than 2 litres, we get slightly excited about it and would refer perhaps for overnight oximetry and input from the Oxford Sleep and Ventilation Service. So just to be aware of that. But if someone's got bulbar involvement, their lip seal's rubbish, so you may get a dodgy reading, so just to be aware of that. But these questions are worth asking someone, because that might give us an indication if there's respiratory muscle insufficiency and diaphragmatic weakness. So they may become more breathless, they may have shallow breathing. Lying flat, they may become breathless. I had a lady who said about her husband, she said, "Oh, it's very strange. When I laid him down, he went a bit blue." I was like, okay. So, and that's probably really important to know if you're delivering care, you know, look about how you're positioning someone. Do they need their NIV on before you've lied them flat? Can you tip the head of the bed up, and you can have like use the tilting mechanism of the bed, just to be aware of that. A weak cough or a weak sniff, so they can't clear those secretions, they may not be able to blow their nose. So you might be looking at breath stacking, where you breathe in again, 3 breaths in and cough. A weak voice, reduced voice volume, would indicate perhaps that there's a problem. Sleep disturbances, they might have really vivid dreams, that sort of not going into that deep sleep, not getting so very, very tired. Daytime sleepiness, so they're dropping off, catnapping during the day. Waking up with morning headaches, feeling hungover. So this isn't because you've had too much sweet sherry the night before. This can be, you know, you can always check that out. But just these are things that you have to think about. A poor appetite until later in the day because they haven't breathed off those levels of carbon dioxide that have been accumulating overnight. So actually, I don't have much breakfast. They're losing weight. What have you been eating? Well, I haven't actually eaten much breakfast. I don't actually feel like eating until later in the day. Or a feeling of fullness. Very tired, very irritable, confused, drowsy, coma. That's quite sort of significant, obviously. The other thing also probably to mention in that is nocturia, getting up in the night to go to the loo, because they're not getting into that deep sleep. They're waking up, they're thinking, oh, I must need the toilet. So these are things that we'll be looking at that would then start us thinking we need to look at further investigations for this. You do that one. You can do that, yeah. So yeah, emergency paramedic card. So we give people laminated copies of this, and one of the reasons was it's fairly new out. There's a really, really good YouTube film. Again, you've got that link. Please look at it. It will take you probably about 5 minutes, explaining about why you have to be careful with using oxygen in MND, because basically it will knock off someone's respiratory function. The reason that we laminate the copy of the paramedic card for the patients is it's a scary place to be when you've got a rare condition and you've got someone coming into your house in an emergency going, oh, don't know about MND. Yeah? So we decided the best thing, because this is such a good guide, was actually laminated it and gave it to people. If they were in that situation, the first thing they could do was hand it over. And the feedback has been phenomenal for doing something really, really simple. And it's reassuring, and that they've got something to give to professionals. Because I think often we find with this cohort of patients, when they phone the emergency services, they've got to the end of what they can do themselves. And a lot of these people can do an awful lot themselves. So just sort of being aware of that.
Paramedics are grateful as well, aren't they?
Yeah.
For having that information, because not everybody's come across an ND.
Yeah. Yeah, go on then.
Yeah. So when
You can see this carefully rehearsed.
when we're approaching end of life, we prepare a just-in-case kit with medication for pain and breathlessness, just to manage those symptoms, anxiety, and also for respiratory secretions and saliva management. So at this point, if not before, this is when also the hospice team generally get involved in a patient's care. Some can be given by carers, and some have to be given by health professionals. Some are in injection form and some are in liquid form. So with the PEG, I think that's a benefit, because they don't have to be injected. They can continue to have their oral medication, and that will just obviously ease their symptoms as they approach end of life.
I would say that we work closely with Willen and the Willen at Home team for this cohort of patients, and most of the complex neuro. We think about the movement and postural problems. The MNDA worked collaboratively with wheelchair services, and so there's now this neuro chair wheelchair, so slightly more high-tech, high-spec that's available through wheelchair services. We may consider neck supports, although we have varying degrees of success with that, because I think it might help to keep someone's neck up. But if they've got swallowing problems, and then that position is going to make the swallowing more difficult. And also, if you can't breathe, it can be quite uncomfortable as well and scary. So you might be looking more at positioning in chairs rather than necessarily putting collars on. We may be looking at a range of orthotics to help with sort of splinting, depending on what's is assessed for. Adaptations to the environment, and that would be something that we'd hopefully look at quite early on, looking to plan ahead. We know we've got a short window of opportunity. We want to get things in place. We may consider walking aid when someone's still mobile, and reviewing those. The environmental controls, so how people can work with their environment around them. And there's amazing service through the Specialist Disability Service in Oxford we can refer into. And they can link in people's televisions and telephones and goodness knows what else. We've got people that are still able to use computer systems. I had a lady, again, fairly recently, who was fiercely independent, had a lovely family, but she wanted to be independent, and that was a really big thing for her. And she was worried about what would happen when she couldn't do her online banking, because there was no way she wanted her family to be able to do it. And we linked in with the Specialist Disability Service, and up until the day before she died, she could still operate her laptop computer system using an eye gaze system, and it gave her a feeling of control, which was really important. She could also switch the lights on and off, turn the heating up and turn the telly up and down, and which, you know, it was control. We look at rise and recliner armchairs. We work with our therapy colleagues about getting a specialist seating assessment, but also the MNDA, we can get some grants towards that. Mobile arm supports, again, things gadgets that can help with arm movement if you've got minimal movement, that can help with feeding. And also we'd be looking at spasticity management, which can be a problem with this cohort of patients. I think this has been a theme right the way through, something I'm really, well, I could, again, keep talking probably until tomorrow. Advanced care planning is so important with our MND patients, to offer them the opportunity. Not everybody will want to complete an advanced care plan, but it's about the opportunity of getting someone's thoughts down, and it's their thoughts, so that we know what they want in the future and perhaps what they don't want, but also to give them a voice to make sure that we get it as right as possible, and hopefully stop inappropriate intervention. So really, really important. Just to be aware, obviously, we have to consider mental capacity within the advanced care planning process, but it does give us an opportunity to have those conversations and give people some control over something they have no control over. And I'd like to direct you to the MNDA website, Motor Neurone Disease Association website, the professional information page. There is so much on there now. Up in the top in the middle, the community of practice. I really do urge you to register with that because there is so much information and webinars and training that comes through that. There's a lot of resources that have been stored as well. So really worth having a look at. There are specific publications for all different types of health and social care professionals, GP guides, acute and emergency medicine. And again, the link should hopefully be in your pack, the ones that I thought would be useful, but please do familiarise yourself with that area because it's about getting that information. Also, there is a nice guideline for motor neuron disease. I don't think there's any for any of the other sort of conditions we've talked about today, NG42. And it gives us sort of basically a whole platform of information about recognition and referral, information and support of diagnosis. So it gives us those standards, what we should be looking at cognitive assessments, prognostic factors, organisation of care, right through to planning end-of-life care and psychological and social support. And within them, they give you sort of guidance on management of muscle problems, saliva management, what we should be looking at, equipment adaptations, nutrition, gastrostomy, communication, cough assist, and cough effectiveness, and NIV. And also specific recommendations for members of the MDT. So again, it's out there and it's accessible, so well worth looking at. The video resources we mentioned, obviously there's the MyTube, which talks about alternative methods of feeding. Whilst it's MND specific, we found it useful with other neuro conditions to just give them an idea of tube feeding. The My Breathing website, again, really, really useful information. The oxygen use in MND, again, worth understanding and looking at. And also there is an advanced care plan video that was produced in conjunction with the Open University. And it's got a number of people with neuro conditions explaining why they've completed an advanced care plan. Quite an easy watch. And also the info in your delegate pack, because I went a bit crackers with the QR codes. So I'm going to hand you over to Anne in the back, and then we can have some questions. So Anne Anderson is I can never get your title right, but you work with the Motor Neurone Disease Association, and you cover Milton Keynes. And I can remember an old title, but it would be really, really ancient. So, Area Support Coordinator.
Hello. I'm just going to tell you a little bit about what the MND Association does to support people, both locally and nationally. I'm not going to go into everything because, like Anna said, we could talk for forever about it. But I'm just going to tell you a few bits and pieces about what we do. Just picking up, somebody spoke about research and things like that earlier when you were talking about the genetic components. We do a lot of research in partnership with lots and lots of other organisations. I think we're probably the biggest funder in this country of research. We do a day every year called an Encourage Day, which is coming up in July. Registration for that is closed now, but I would encourage you, if you are interested, to look next year when it comes about again. It's probably about 25 early researchers into MND, showcase their work and what they're looking at the moment. Hopefully one of those one day will find some treatments and a cure, potentially. But have a look out for it because it's really, really good. So what do we do to help people? Probably one of the biggest things, and maybe the first thing that people will do when they look on our website, is call MND Connect, which is our support line. They are able to offer advice and guidance to people, or they can sort of point them in the right direction of who they want to contact and where they want to go for support with MND. Quite often that is to us because we work regionally. So I work in the Central Midlands area. So we can then look at what's locally available to people, and that would be putting them in touch with things and people locally that can support. Sorry about my voice. Another thing we run alongside that is our benefits advice service, which is dedicated to people with MND. We work in conjunction with Citizens Advice Service, so we can signpost to there. They can check with people what benefits they're on, what benefits they're available to, and they can help to apply for them as well, which is really useful. We've got information resources on our website, very specific information resources. So if someone's got problems with saliva management, we have a leaflet for that. We have a leaflet for everything on there, and they are updated as things change. So if new medications come along, then they will be updated to reflect that. One of the big things we do are support grants for people. So we've got a variety of grants that people can apply for. One of the big one is our support care grant, and that's for any equipment that isn't supplied by health and social care. So that could be rise and recline chair, as Anna mentioned. It could be rental for a stair lift, any bits and pieces like that. And we can offer up to £1,500 for that. It could be adaptations for your house. They're not means tested. That is our only grant that needs to be completed by a health and social care professional because it needs to be assessed. Anybody could want to get a stair lift in, but they might not be able to sit up straight on it, so it wouldn't be very helpful. So that needs to be assessed. We also have quality of life grants, for that's up to £500 per time. So that would be anything that would enhance the person's quality of life. It could be a holiday, could be a spa day, could be, we funded somebody to go to Wembley. It could be anything like that. We can be very creative in what we give our money to. We have grants for carers, again up to £500, same sort of thing. Driving lessons, things like that we can fund. We've got children and young people's grants. One of the strangest ones we did was we funded pole dancing lessons for a young girl, just because she needed a little bit of a break and that's what she liked doing, so we funded that for her. It could be theme park tickets or something like that. And one of the ones that we picked up recently is a cost of living grant, so that's for £350, and that's a one-off payment once a year. So you can have up to £3,000 in any 1 year. Now that's not running January to January, that would be from when you apply for your first grant and would go on that way. So that's really, really useful for people that we've got that available. What else do we do? Oh, so talking about children and young people, we've got our own children and young people's team. They do an amazing job. So we run days for children and young people. They do memory boxes, they'll work within schools, and we're able to refer to Bernardo's for counselling for children as well, which is a really, really good thing that we can do. We don't have a counselling service for adults at the moment, which is a real shame because there's a real lack of psychological services for people with MND, but hopefully we're having a bit of a revamp at the moment, so that might be something that might come about. I hope.
I think you can access psychology through the MND Care Centre, and also we've been able to get counselling via Women Hospice as well.
Another big thing we do are our support meetings. So we do, I know someone mentioned earlier they've got online support meetings. We do have online support meetings. Strangely, from our side, they're not as popular as our face-to-face support meetings. But our online ones, we've been able to kind of diversify a little bit. So they're not only for carers and people with MND. We've managed to kind of specialise a little bit for ex-veterans. We've got one for those. Going kind of alongside what you were saying about maybe it's more active people or fit people. So we found that there are quite a lot of ex-veterans that have joined that. And in America, they do recognise ALS in people with that are ex-veterans, and they do get they get a pension for it. So that is recognised in America, but it's not here. So we do specialised support groups, and we do face-to-face groups. So we do have a group that's run by our local Milton Keynes branch, who are so good. It's all run by volunteers. They work really closely with Anna and Karen. They really, really do support the people within Milton Keynes. So our group runs the first Thursday of every month, and they're really, really dedicated. And that's for people with MND, carers, family, and bereaved carers can come along to that as well. So that's worthwhile knowing about. One other thing we do, which we don't have in Milton Keynes at the moment, are specially trained volunteers called association visitors. So they go out to support people emotionally. They don't go out and do any care. They're not a sitting service or anything like that. They're there to support people emotionally and maybe liaise with professionals if people would find that helpful for them to do. Like I say, we don't have any in Milton Keynes at the moment. And I think because the branch works so closely with the specialist nurses, we haven't felt a lack of that service. I think because we just talk to each other, don't we? So we can pick up things as we go along. It might be something, we've had it previously, and it might be something we pick up in the future. But I don't have any volunteers that do that here currently. And one other thing I'm just going to talk about, quite a lot of people have spoken about voice banking. We've got a communication aid service, so they can loan out iPads, they can loan out equipment to support with voice banking as well. And one thing we have done is that we've worked in development with Dell, because we recognised it was quite difficult in the past to do voice banking because you had to say lots and lots and lots of phrases, and it went on for a long time. So we developed a book called I Will Always Be Me. So you can just read that book and record yourself reading that book. It is really sad. It's a very sad book. And then you can do that on the website, and then that will automatically save your voice and bank your voice. And we will pay for any voice banking that's done either through I Will Always Be Me or through Speak Unique or one of the others. And I'm really sorry because my voice is going to go. Thanks, Karen. Thank you. That's about all I was going to say anyway. Thank you.